evening, everyone. This is my first question. Someone who's diagnosed as having Guillain-Barré syndrome is presenting with a rapid onset ascending weakness at 10 days after having a gastrointestinal infection. And there is a plan was made to initiate treatment with the plasma exchange. As you know, the standard treatment for Guillain-Barré syndrome is either usually a plasma exchange or what is that? Or IVIG, IV immunoglobulins. And as you know, plasma exchange, it's quite effective for this condition along with number of other conditions. But sometimes we may run into certain issues. So the question is, which of the following electrolyte imbalance are common with this with plasma exchange? And these are the options: hypocalcemia, hypophosphatemia, hypermagnesemia, hyperuricemia, and hyperkalemia.
Hypocalcemia.
Okay, very good. Why does that happen?
So because plasma constitutes a majority of the fluid portion of the blood, and that contains calcium. So when there is an enormous exchange of the fluid, so it tends to cause hypocalcemia.
Yeah, okay, that is one mechanism. What is the other reason? Anybody else? What is used for anticoagulation? Does anybody know? When you do plasma exchange, we use a certain anticoagulant normally. Generally, we try not to use heparin purely because when you do plasma exchange, just you mentioned, you also remove some of the clotting factors as well too. Because sometimes you don't exchange everything with FFP, you partly exchange it with albumin and then partly exchange with FF, fresh frozen plasma. Yeah. So what is the anticoagulation which we typically use for this condition? No? Okay, not a problem. See, basically, what we do is that we use citrate as an anticoagulant for this treatment. Okay. So what happens is the citrate, the calcium is chelated by sodium citrate. So that is also one of the other reasons for developing hypocalcemia. So generally what we do is that when somebody is undergoing plasma exchange, whatever the etiology might be, we often have to give them a calcium supplementation, usually in the form of IV calcium before and during the procedure, so that you can reduce the risk of hypocalcemia. There are other complications like cardiac hypolemia, anaphylactic reactions, etc. But the most common electrolyte disorder or abnormality that you will come across at the time of plasma exchange usually is hypocalcemia. And this is one of the main reasons why these people develop hypocalcemia. So generally, it's very well tolerated. Anaphylactic reactions and all are relatively common because we're infusing FFP from other patients, etc. So you often give them, prophylactic antihistamines as well as steroids at the time of initiation of treatment. There are various indications when you might give plasma exchange, and these are the conditions which is commonly used actually. When it comes to nephrology, the three main indications that one would use plasma exchange will be Goodpasture syndrome. You're familiar with that? We had a case on that last time when I did a class about 10 days back. ANCA positive vasculitis, typically we don't use it for everybody with ANCA positive vasculitis, but we consider that particularly if somebody's got a pulmonary hemorrhage, because one of the bad prognostic markers in both Goodpasture and ANCA positive vasculitis is the presence of pulmonary hemorrhage. So we want to bring the antibody down as much as you can, and one of the treatment that you would deploy would be plasma exchange to remove the antibodies. You also do other treatment like intravenous steroids, cyclophosphamide, etc. But if they have evidence of pulmonary hemorrhage, particularly you almost invariably use it in Goodpasture syndrome because most of them, they do have pulmonary hemorrhage. But in ANCA positive vasculitis, you only give it if the renal function is getting out of hand or they develop pulmonary hemorrhage requiring ventilatory support, etc. Otherwise, typically, we don't need to do that. The third indication with regards to nephrology one might use that would be hemolytic uremic syndrome. Again, we get a scenario, last week, and particularly in what we call as an atypical HUS, which is a non-diarrhea related hemolytic uremic syndrome. There are other indications that one might use it as well, but we often have a lot of better treatments. For example, multiple myeloma. I can't remember the last time we used plasma exchange now because we do have other effective therapies like bortezomib, etc. Okay. Sorry, any question on that one? Sorry, just 1 second. Yeah. Okay, fine. Now, the next question is, it's a 32-year-old male who is being investigated for hemoptysis. Okay. He is a non-smoker and has no respiratory symptoms of note. His investigations have been done. He's got renal impairment with a serum creatinine of 201 micromoles per liter. He's got 2+ protein and plenty of RBCs. Okay, fine. All right. Sorry, I'm just refreshing myself with regards to the question. So what sort of things will go through your mind when you have a scenario like this?
ANCA-associated vasculitis.
Okay. See, basically the way you look at it is that he's got evidence of both renal and lung involvement. Yeah. Yes, isn't it?
Yes.
So he's got hemoptysis and he's got evidence of glomerulonephritis as evidenced by elevated serum creatinine, proteinuria, and hematuria. So what I call that is we call it as pulmonary renal syndrome. Okay. 1 second. For some reason, my Zoom is not letting me open the chat. I don't know whether it's something to do with Mac. I'm not too sure. So if you have any things, you can ask me directly. Actually, otherwise I'll have to stop the slideshow and look at the chat. That's what I have to do. Okay. So he has something called pulmonary renal syndrome. So what are the causes of pulmonary renal syndrome?
Good pastures.
Okay, very good. Somebody already mentioned ANCA-positive vasculitis. Yeah. Yeah, you already mentioned that somebody. Yeah. Okay. So ANCA-positive vasculitis, good pastures, and then
Granulomatous is polyangina GPA.
Yeah, they're all very similar. Yeah, it's like ANCA-positive vasculitis. Yeah. Okay. Rarely you can have something like SLE as well. But that typically is very, very rare. But those two are the more common causes of good pastures and ANCA-positive vasculitis or granulomatous polyangiitis, whatever. Those two are the major causes of those things. So the way, we went through that the other day, but remember that good pastures generally tend to be a very rapidly progressive. Generally, symptoms tend to come in over a matter of few days to 1 or 2 weeks, whereas vasculitis can linger around for a much more longer time. So typically, the patient good pastures tend to be a lot more thicker than somebody with a vagueness or an ANCA-positive vasculitis. Okay, and again, ANCA-positive vasculitis, the other clue will be upper respiratory tract involvement. Remember, we discussed the other day. They may have features of sinusitis, etc. Yeah, so if they have that, it's most likely to be ANCA-positive vasculitis rather than good pastures. This is something will give you a hint. Okay, she done a linear renal biopsy, and what you see is the linear IgG deposits along the basement membrane. So now, what is the most likely diagnosis, or what antibodies are likely to? Sorry.
Good pastures syndrome.
Good pastures. Very good. Sorry. Just speak. I don't know whether it's my audio. I'm not too sure. Yeah. So it's likely to be good pastures. What will you expect in same question? What will you expect in ANCA-positive vasculitis?
In ANCA-positive vasculitis, there will be no deposits. It's a posse-immune deposit.
Exactly. Very good. Yeah. Very good. That's right. So that is what you will see. That is why it's called posse-immune glomerulonephritis. Because if you look at the light microscopy, what will they both will have? What will you find in the light microscopy?
In light microscopy, usually it's a rapidly progressive picture.
No. Rapidly progressive will be
sorry. Granulomatous.
Not Crescentric glomerulonephritis. That's right. Yeah.
Sorry.
So with the light microscopy, one cannot distinguish between good pastures or ANCA-positive vasculitis. The only way to distinguish that will be by looking at the immunofluorescence or by looking at the serum markers like ANCA, anti-GBM, etc. Okay, but in the immunofluorescence, what you find in good pastures is linear IgG deposit on the basement membrane, whereas in ANCA-positive vasculitis, it will be posse-immune. What I mean by that is basically you do not see any immune deposits. Okay. Likewise, let's say the similar patient, there is no evidence of hemoptysis. Instead, it's a 30-year-old woman or 25-year-old woman, whatever. You're suspecting it's going to be something like SLE. Then what you might see, we discussed it the other day. This is more like a rigorous refresher for the
full house
exactly
chain.
very good. Okay, this just again reinforcing it so that you guys remember it really. So if you see SLE, what you find that there will be IgG, IgA, C1q, C3, etc. So if you see that full house immunostaining, because SLE can also present with a crescentic glomerulonephritis, particularly if you have a diffuse proliferative glomerulonephritis. Okay, so though crescents are a bit rare, but you can still get it. So if you have a full house immunostaining, think of SLE. The linear IgG, think of good pastures. If it's pass immune or no immune deposits, you think of ANCA positive vasculitis. Does that make sense? Yeah. Yeah, it's clear.
Yes, sir.
Yes, sir.
Yes. Okay. Any
Yes, sir.
question? I'm
Yes.
I'm really sorry. I'm for some reason Zoom is not. I don't know whether it is because of my laptop. I'm not Mac. I'm not sure, but I'm not able to open the chat box. If you do have any questions, can you please stop me and ask me? I don't mind that. Otherwise, I'll have to look at it only at the end, because when I'm sharing it, I know you guys are sending me chats, but I'm not able to. Just to 1 second. The only other option is to go to, then I have to stop the slideshow. I don't want to. Okay, so if you have answers, please tell me, okay, rather than typing it in the chat box. Yeah, because I'm for some reason, otherwise I have to stop the slideshow and then look at this one. I think it's maybe something to do with Mac and Zoom. I think unfortunately I'm not able to solve that right now. 1 second. Okay, so if you want to say something, just tell me. I'll stop and then I'll continue with that. Okay. Okay. So you know the answer. Here it is: anti-GBM antibodies. Which is so likewise. If it is like a IgA nephropathy, you will see IgA in the mesangium, etc. Okay. So typically they are against type 4 collagen. There's a couple of things to remember with regards to anti-GBM disease is that there is a higher risk in smokers as well as in young men for pulmonary hemorrhage. So if they give a history of something like a vasculitis, young men smoker, think whether it could be anti-GBM disease. Okay. And the treatment is, the standard treatment is plasma exchange with IV steroids and the cyclophosphamide. Okay. Does that make sense? You have any questions on this?
No, sir.
Oh, fine. Just 1 second. Actually, the same thing. I just want to ask 2 things actually before I forget it. Okay. So let's say you got a situation. As always, it's important not just to answer the questions to know more about the condition that we are dealing with, we were treating. Let's say that you've got somebody with an ANCA positive vasculitis or an anti-GBM disease presenting with an acute kidney injury. So what will be the initial treatment of choice? I briefly mentioned that here. I just want to clarify and discuss it. If you have any questions, because that's also equally important. Just a couple of pointers there. We got a guy. Okay, we diagnosed the disease. Let's say it's a 35-year-old guy. We diagnosed that he's got anti-GBM disease. We done a biopsy, confirms that. Okay, he's got pulmonary hemorrhage. Yeah. So how would you treat him? That's my question. Yeah. How many treatment do you do? What sort of treatment would you give? That is my question. Yeah, one at a time, please. Yeah.
Pulse dose steroids initially.
Okay, good. How many days would you give it for typically?
3 days.
Okay, very good. Then is that alone going to be sufficient?
We need to wait and observe.
Okay.
And then if it's severe, probably we'll go ahead with plasma exchange, or else if we go with cyclophosphamide.
Okay. No. What you have to remember is for anti-GBM disease, invariably you have to go for plasma exchange. Okay. It's not a very clear cut in ANCA positive vasculitis, but when you have an anti-GBM disease or good pastures, you have to go for you have to go for plasma exchange. There's no other choice, because otherwise these patients will, even if they don't have a pulmonary hemorrhage at that time, they will go on, they are at a very high risk of developing pulmonary hemorrhage, etc. Because these antibodies are a lot more harmful than ANCA antibodies. Okay. So if you diagnosed it, you'll give them IV steroids followed by oral steroids, and then you choose cyclophosphamide. You can choose, let's say, IV or oral cyclophosphamide. Okay. Now, let's say, instead of this one, let's say we are dealing with a 25-year-old woman. Okay. And let's say she's got an ANCA positive vasculitis, but she's got a rapidly progressive renal impairment. She's got no evidence of pulmonary hemorrhage. what would be the treatment? What drug will you choose? What sort of things would you discuss before going for treatment with the cyclophosphamide? Or what is there anything else you can consider?
Here, the reproductive phase of the lady has to be kept in mind.
Can be considered.
No, please wait, one at a time, please. Yeah, go on, ma.
So, because cyclophosphamide can cause problems with further conception,
okay,
the patient has to be made aware of the other options available, the other immunosuppressant therapies which are available.
Okay.
And maybe steroid plus other immunosuppressant group of drugs can be prescribed to her.
Okay, we will come back to that minute. I'll ask the guy who said about what you said about something about azathioprine.
Yeah, better to go ahead with azathioprine.
Okay, no, that's not, see, but here, see, when you come to this sort of things, whether it's a vasculitis or SLE, whatever, what you have is, you have two phases of treatment, okay? One is called the induction phase and then the maintenance phase, okay? Azathioprine is not something we consider for induction in vasculitis or even SLE, okay? So the induction phase is usually IV plus oral steroids. Then you have either cyclophosphamide, any other drug you can use. Anybody else is familiar with any other drug? Exactly, that's right.
Yeah.
So if you have a lady who's of reproductive age, let's say she does not have a life-threatening disease like a pulmonary hemorrhage or something like that, the life-threatening disease, it gets very, very tricky. So you may not have a much option apart from going for cyclophosphamide. But if it's not a life-threatening disease, one option is you can discuss with them and go for rituximab. With rituximab can be safely given. It does not affect the fertility. Okay. Whereas cyclophosphamide, it certainly can cause infertility, particularly with the increased dose over time, like cumulative dose over time, etc. Actually, there is very little evidence that whether between IV and oral cyclophosphamide with regards to treatment in renal disease, at least as far as I know. Okay, that they are very similar, depends on individual preference. For example, I personally prefer IV, some guys prefer oral cyclophosphamide. Usually it's not there are no major differences. Okay, now we already discussed it. One is that what is that you can go for rituximab, particularly in young women. You're worried about fertility, etc. What are the other side effects one would discuss before starting cyclophosphamide?
Hemorrhagic cystitis.
That's actually is very, very rare. We don't even use that. What is that drug olden days we used to give, Mesna. We don't give that. That's incredibly rare. It's something you should be aware of, but there are other things one need to be more aware of than that. Yeah. Anyone? Come on, there are a lot of things. There are few things which are very, very common. You already mentioned the most important thing, which is the fertility. The other thing is, see, any immunosuppression, what is it going to do?
Neutropenia,
exactly. Yeah, that's right. So marrow suppression, increased risk of infection, hair loss is a major problem in some people. Some women are particularly very worried about the hair loss. Fertility, we already discussed it. Risk of malignant solve is very, very rare. I mean, these are the major side effects. That is the increased risk of hair loss, immunosuppression, increased risk of infection, increased risk of malignancy, and we already discussed about fertility is one of the most important things. Actually, it can also cause male infertility as well. A lot of times we often ignore that, but even in the men, you always have to bear in mind the risk of infertility as well when you give cyclophosphamide. So just to summarize really, so the induction phases usually go for steroids plus cyclophosphamide. You can consider rituximab in people who are worried about fertility or other risk of immunosuppression, etc. And then you go for maintenance phase. And usually with regards to vasculitis, the maintenance phases, usually steroids plus azathioprine. Though one can also use mycophenolate as well. With regards to SLE, it's actually MMF is generally preferred for maintenance phase compared to azathioprine. Okay, got that?
Yes, sir.
Yeah, understood. And any questions before I move to the next question? Okay, right, we'll move to the next question. A 65-year-old man is diagnosed with renal cell carcinoma. Which one of the following hormones is least likely to be present in excessive levels? So it's a parathyroid hormone, growth hormone, ACTH, renin, and erythropoietin. So this is question of we had a case last week, remember, the renal cell carcinoma last 10 days back, whatever, about a renal cell carcinoma presenting with something else. So here it's about ectopic hormone production or something like that, or, with regards to renal cell carcinoma. Anyone?
Is it growth hormone, sir?
No, you misunderstood the question. One of you misunderstood the question. Which one of the following
Yes.
hormones is least likely?
Least
See,
likely.
I always tell people sometimes MRCP exam is like a test of English rather than test of medicine. So it's very important to read the question correctly, because sometimes it will say most likely to be, it will say all the following are true except, which is most likely to be present. So it's very important to read the question. Obviously, erythropoietin is most likely to be present.
More.
So it's renal.
Okay, can you just hold on 1 second, please? Yeah, just 1 second. I just had a call from the hospital. Just be online. Yeah. Just 1 second. Hello? Yeah. Okay. Sorry, I had a call from the hospital. I had to, because I'm on duty. 1 second, just 1 second. Okay. Yeah. So as it is, as much as it's a question of
Growth hormones.
So it's renal.
Growth.
Yeah. Sorry, 1 second. I'm just had a little bit of problem with my audio. Okay. No, it's actually is growth hormone. See, almost all hormones can be produced except growth hormone. Now, you probably haven't come across ectopic growth hormone production before. No. See, with renal cell carcinoma, 2 to 3 things we need to bear in mind. One is that the typical presentation with hematuria, loin pain, abdominal mass, and sometimes they may present with weight loss, fever, etc. You remember we had a scenario a 2 weeks back, where we had a patient with renal cell carcinoma who had a varicose field with a left-sided lesion, because, as you know, in the left side, what happens? Where does the renal vein drain? Sorry, the testicular vein drains to. You remember that? You've forgotten?
Renal vein.
Yeah, that's right. So it doesn't go to IVC
Left vein.
directly. So particularly if you have a left-sided renal mass, you are more likely to get varicose vein. So sometimes these patients can present with varicose vein. If you got a malignancy with the varicose vein, the top differential is always is renal cell carcinoma. The other thing is association with von Hippel-Lindau and tuberous sclerosis. There is also slightly higher risk in polycystic kidney disease, but it's quite rare. I don't want you to bother too much about it. The more important associations are with von Hippel-Lindau and tuberous sclerosis. Okay, so literally any hormone can be produced, but the answer which is least likely to be produced is growth hormone. Okay. Now, we discussed a question on autosomal dominant polycystic kidney disease the other day. Now, I'm going to something else also, which is, sometimes can be asked in the exam. It's all the following statements are true regarding autosomal recessive polycystic kidney disease. You guys know about autosomal recessive polycystic kidney disease? You heard about it?
Yes, sir.
Yes.
Yes.
Yes, sir.
Okay. All right. Okay. Look at the options and then let me know. No. Liver involvement is common. It's due to a defect in. So remember, read the question correctly. All the following statements are true except. So the question is, which one of the statements is false? Okay. So liver involvement is common. It's due to a defect on chromosome 6. It's less common than autosomal dominant polycystic kidney disease. Onset is typically in the 3rd decade and can be diagnosed in prenatal ultrasound.
It's onset
B-
still 3rd decade. Because
B option.
the inventor.
This is the question. All the following statements are true, except, so basically, which one of the following is false?
May be diagnosed in prenatal ultrasound.
Onset is typically in the third.
Yeah.
Defect on chromosome
What-
6.
Okay.
The onset is typically in the 3rd
Onset
decade.
typically in 3rd
Yeah.
decade.
So this we usually see that in actually young kids. They're often born with this condition, because
Childhood.
that is why it can be diagnosed in prenatal ultrasound actually. So because adult or autosomal dominant polycystic kidney disease, you don't diagnose it till they're in about 20-25, because these cysts are very, very small. You actually can miss them. So we actually tell them if somebody's got a family history, they're worried about them developing it. What we normally tell them is don't do a screening ultrasound till at least they're about 25 or so. However, when it comes to the recessive polycystic kidney disease, what happens is that these kids develop cysts actually before they are born. These kidneys are often huge. When they are born, the kidney is huge. And sometimes within a year or two of life, they can develop renal failure. So this is completely opposite of what happens with autosomal dominant polycystic kidney disease. So as I said, it happens in a much younger age group. You find them at the time when they deliver, or even in the rarely when you do an antenatal ultrasound. This is due to PKHT gene 1, which is in chromosome 6, which encodes fibrocystin. Similar to adult polycystic kidney disease, they develop cysts in both the kidneys, whereas in the autosomal dominant one, in the liver, what you normally get is such cyst in the liver alone. But however, what is the hallmark of this condition is that they get hepatic fibrosis and they can even develop liver failure as well. So this is something to bear in mind. So if you got a young person, there is a suspicion of liver disease and you find cyst in the kidney, this is one of the differential you have to think of, whether it is an autosomal recessive polycystic kidney disease with hepatic fibrosis, okay? Whereas in the other adult polycystic kidney disease, you don't get hepatic fibrosis. You only get cyst in the liver, cyst in the pancreas, cyst in other places, etc. Okay? I got it?
Yes.
Yeah. Any questions on this one? So it's a recessive. So obviously they need to have two genes, both parents have to have it. It's more common in, marriage between close relatives. And as I said, liver fibrosis, always remember that hepatic fibrosis. Okay? Right. Next question is, a 62-year-old male is being evaluated for persistent proteinuria. He has a past medical history of multiple myeloma that is recently relapsed. He undergoes a renal biopsy, and the light microscopy with Congo rate stain reveals apple green pyrefringence under polarized light. Relatively easy question, actually. So this is what a typical biopsy with a polarized light would look like in this condition. Okay. And what is the most likely diagnosis? Membranous.
Amyloidosis.
Any other diagnosis is possible? Any other diagnosis can be possible or not?
Membranous nephropathy because of proteinuria.
Because I asked you a question, you are trying to come with a second diagnosis?
No, the answer I suspected as membranous.
Okay. You suspected membranous. Why?
No, probably it will not be a straight question. I usually so I thought.
Okay, fine. Okay, second question: what sort of amyloidosis this is going to be?
Because red stain, Congo stain.
No. What type of amyloidosis did I say? That was the question.
Amyloidosis B.
Light chain.
Light chain.
No, what are the? Yeah, that's what are the two types of amyloidosis? Amyloidosis A and
AEB.
AA and AL amyloidosis. Okay?
Yes.
So when do you get AA amyloidosis?
It's secondary to infections as well.
Yeah, chronic infections or chronic inflammatory conditions as well. You can get it with the TB, you can get it with Crohn's, you can get it with rheumatoid arthritis, etc. So if you have a scenario of those sort of patient who's got a chronic condition for a long time, now come in with proteinuria and he's got a nephrotic syndrome, you've done a biopsy, you may get amyloidosis, then your differential is going to be AA amyloidosis. Okay. Whereas when it's related to multiple myeloma, you have excess production of monoclonal light chains, you're going to get AL amyloidosis because the treatment is going to be very different. Got it? Can you guys? Yeah. Okay. So this is likely to be AL amyloidosis because it's AL. There is no evidence of a pre-existing chronic condition. The only condition he has is multiple myeloma. Yeah. So if you got a multiple myeloma, you can got a renal biopsy. Sometimes you can get a light chain nephropathy as well. But typically that does not present with nephrotic syndrome. Okay. You have a lot of proteinuria, but typically the light chain nephropathy does not present with it. Some tend to present with acute kidney injury. They will have a proteinuria, but not necessarily nephrotic syndrome. And again, you don't get these Congo red stain. Actually, for exam purposes, if they mention that there is a Congo red stain, the top differential you have to think of will be amyloidosis. Okay. Yeah, got that?
Yes, sir.
Yeah. Okay. So, so AL is also called as primary amyloidosis. It's typically with plasma cell dyskaryosis like multiple myeloma. So usually you treat these conditions with immunosuppressive therapy, etc. for primary amyloidosis. Whereas secondary amyloidosis, as we already discussed, it's associated with chronic inflammatory conditions like rheumatoid arthritis, Crohn's, or tuberculosis. So here the treatment will be the treating the underlying condition. You treat the underlying condition, which could be rheumatoid, Crohn's, tuberculosis, etc. So that is what the treatment. That's why it's important to know what the likely diagnosis is. Right. So a 72-year-old male with end-stage renal failure due to IgA nephropathy attends for review of his painful skin lesions. The investigation shows hypercalcemia and hyperphosphatemia. The lesions are large, covering most of the lateral aspect of the lower right and upper left leg. The skin is mottled with black necrotic tissue. The rest of the examination normal. The observations are stable. So this is what a typical picture would look like. Okay. So this is somebody who's on dialysis, who's got a hypercalcemia and hyperphosphatemia, and it comes with skin lesions. Okay. So first we'll go to the diagnosis in a minute. What is odd about this electrolyte abnormality here? What do we typically get in renal failure with regards to calcium and phosphate?
Hypocalcemia and
Hypocalcemia and hyperphosphatemia.
Okay, so when will they develop hypercalcemia and hyperphosphatemia?
More treatment with vitamin D actually.
Okay.
Secondary hyperparathyroidism.
Calcium. Sometimes calcium given for phosphate correction, sometimes calcium binders.
Okay, yeah, sometimes we use calcium phosphate binders. That can one do that. That could be one thing. That's actually one of the common issues that we will face. Yeah. So because almost most dialysis patients tend to have a high phosphate unless they're nutritionally very weak or they're not taking enough protein, etc. Then they may have a low phosphate, actually, which has with worse prognosis. Generally, they will have a high phosphate. So the high calcium could be due to the calcium supplementation, vitamin D supplementation that we give to treat it. Okay. Why else they might develop it?
Probably calciphylaxis, probably.
Long
wait. No, that is calciphylaxis is the diagnosis. That is not the cause of hypercalcemia. It happens because of hypercalcemia and hyperphosphate.
Tertiary hyperparathyroidism.
Hyperparathyroidism.
Secondary hyperparathyroidism, sir. Secondary hyperparathyroidism.
No, listen. Okay, in secondary hyperparathyroidism, what should the calcium be?
No, this is not secondary. This is tertiary.
Okay, very good. Okay. So basically, yeah. See, in renal failure, because I don't know whether I can put a draw just 1 second.
Long-standing secondary hyperparathyroidism. Tertiary.
Yeah. Just 1 second. 1 second. I'll just see whether I can.
Autonomic regulation.
Yeah. Just 1 second. Just one. You can probably see my. You can see my typing, no? Yeah. Yes.
Yes,
no?
sir.
Yeah. Okay. The point I want to make is, see, in renal failure, so let's say somebody is on dialysis. What actually happened? What is not? Let's forget about dialysis because this is important. No, I actually there's a question I should have added, but some reason that got left out. See, you typically in renal failure, what you get is secondary hyperparathyroidism. Yeah, that's what we typically get. Why does that happen? You have because normally what happens in renal failure?
Due to hypocalcemia.
But why does the calcium go down?
Less vitamin D.
Vitamin D.
Vitamin D.
What vitamin D deficiency? It's very important. What is it?
125 hydroxy vitamin.
Exactly. Yeah. So normally, when you get the vitamin D from the sun through the skin, so what happens? It gets activated in the liver and then in the kidney. Yeah. So you get hydroxylation happening both in the liver and the kidney. So that active vitamin D is involved in absorption of calcium and phosphate. Yeah.
Yes, sir.
Yeah. So that's right. So what you have in general in renal failure is low calcium and high phosphate. Yeah.
Yes.
So because the kidney's job is also, because there is as the renal function gets worse, the kidney is not able to retain calcium and get it off phosphate. So as the renal failure progresses, what happens is that you develop hypocalcemia and hyperphosphatemia. Yeah. And they both will stimulate the release of PTH. Yeah.
Yes, sir.
Yeah. So
Yes,
that is one reason. Okay. They stimulate the release of PTH. Second thing is that active vitamin D has got two jobs. One is it increases the absorption of calcium and phosphate from the, where does it get absorbed?
GI.
Yeah, from terminal ileum or small bowel. Yeah.
Small bowel, yes, sir.
Yeah. So because there is no enough activity, you are not able to absorb calcium and phosphate. And the second thing it also does is that it acts as like a negative feedback on PTH. That active vitamin D. That is, what is that? Calcitriol. Yeah. 125 dihydroxycholecalciferol. Got that?
Yes, sir.
Yeah. So that is why in renal failure, what happens is that you have a low calcium, high phosphate, and a low active vitamin D all together lead to increased PTH levels. You got that? Does that make sense? Yeah.
Yes, sir.
Yeah. So basically, what you have is that in secondary hyperparathyroidism, what you have is that you have a low calcium, high phosphate, and a high PTH. Yeah. Okay, so what we normally do as a treatment for these patients, because this hyperparathyroidism is also quite important, that's why I'm just covering it. Yeah. Okay, so you have a what's that? Sorry, secondary hyperparathyroidism. So as a due to low calcium, high phosphate, and low active vitamin D, all of them together will stimulate the PTH. That's what normally happens. Okay. So normally what we do is to treat that. We give calcium supplements. We can use phosphate binders if the phosphate is high. You also give them active vitamin D to suppress the PTH. Yeah. That's what we do in patients with CKD. Yeah. Got that? Yeah. Understood or not?
Understood, sir.
Yeah. So now what happens is, once these patients are established on dialysis, they have a high phosphate already. Yeah. And you're giving all these supplements and all of that. What is that? Calcium, phosphate supplements, etc. Phosphate binders, etc. And sometimes this active vitamin D, what it also does is it makes you absorb even more calcium. But that's not the main reason why calcium will tend to go. What happens is, over time, this PTH, this becomes autonomous. Like what would happen in a primary hyperparathyroidism. So normally what happens in secondary hyperparathyroidism is you have hyperplasia of the parathyroid glands. Yeah, normally. But what can happen is, if you have renal failure going on for a long time, what happens is this parathyroid gland can become autonomous, and what it does is it acts on the bone and make it release even more calcium. You got that?
Tertiary hyperparathyroidism.
That sets in. That's what happens. That's why you get a high calcium and a high phosphate. So this is almost exclusive to dialysis patients. You don't see that outside dialysis at all. It must be very, very rare. So if you don't diagnose tertiary hyperparathyroidism in a non-dialysis patient, I mean, it's incredibly rare in non-dialysis patient. Dialysis patients, we see that. So in secondary hyperparathyroidism, you have a high PTH, low calcium, and a high phosphate. In tertiary parathyroidism, you have a high PTH, high calcium, and a high phosphate. So what happens in calciphylaxis is that these patients, because of this, there is an increased, what you call is a calcium phosphate product, and that goes and blocks the blood vessels. So that is why they get this calciphylaxis, which is also known as uremic arteriopathy. You heard about that term?
Calciphylaxis.
Yeah, that is the other name is uremic arteriopathy. So these are the options. So here, so when you have a high calcium, high phosphate, often with a high PTH, in a dialysis patients with the skin ulcerations, the top differential diagnosis is calciphylaxis. Yeah. None of the other thing, there is no history to suggest that. Yeah. And you don't, calcium pyropathic deposit disease, that pseudo gout only affects the joint. Pyoderma gangrenosum, you don't see it in dialysis patients. You might see that in Crohn's, ulcerative colitis, etc. Arterial ulceration is not impossible, but the history doesn't necessarily fit in with that. And erythema nodosum doesn't usually cause skin necrosis as well. So the most likely answer is calciphylaxis. As I said, it's a rare complication of end-stage renal disease. Usually you have a high calcium, high phosphate. It's also called a calcific uremic arteriopathy, and you get vascular calcification because there is a increased calcium phosphate product that goes deposits in the small blood vessels, and so there is decreased perfusion leading to skin necrosis, and typically it's very painful, and they will develop a necrotic tissue which can go on to develop ulcerate. So you treat these patients with more aggressive dialysis, controlling the calcium, controlling the hyperparathyroidism, and controlling the phosphate levels. Yeah. Got that?
Yes.
Yeah. See, hyperparathyroidism, sorry, I should have, you may have had an endocrine. Some reason I didn't have a question on that. That's why I went through that. I remember that I didn't have any question on that. That is why I went through that. Do you have any questions on that? What is the other common cause of secondary hyperparathyroidism? Apart from renal failure.
Nephrogenic? No.
We're talking about.
No, sorry.
Cancer.
Huh?
Malignancy.
Why should it cause secondary hyperparathyroidism? Malignancy, you can have an autonomous parathyroid gland. It's like a PTH rated peptide and all of that. That is, you just you have a high PTH leading to hypercalcemia. The other thing is vitamin D deficiency.
Vitamin D.
We need vitamin D to be converted. No, if you don't get exposed to sun, you don't go out in the sun. So if they give a history of a young woman having, but what will be the calcium and phosphate in that situation?
Low.
We just went through it.
Low.
Yeah. What will be low? Exactly.
Calcium
that's
will
right.
be low.
You need vitamin D to absorb the calcium and phosphate. Yeah. We just went through that. No.
Yes,
so you
sir.
got vitamin D. It's converted in the liver, then the kidney, and then it acts on the gut to absorb the calcium and phosphate. So if you don't have active vitamin D, you cannot absorb calcium and phosphate. So that is why in osteomalacia, that is the other one. It also is a cause of secondary hyperparathyroidism. You'll have a low calcium and a low phosphate. So if you have a low calcium and low phosphate, think of osteomalacia. High calcium and high phosphate, think of tertiary hyperparathyroidism. That's how you have to remember that. Yeah. Okay. Obviously, in primary hyperparathyroidism, the calcium will be high and phosphate will be
High.
No. Primary. Phosphate will be low.
Low.
It will be low.
Calcium is high.
Yeah, that's right. The PTH job is to absorb the calcium and get into the phosphate. So you have too much of PTH, generally in primary. In tertiary, you have high phosphate because the kidneys are gone. Because the PTH is not able to work. That is why you get high phosphate. Yeah. But the job of the PTH in the kidney is to retain the calcium and get into the phosphate. That's why in primary, you'll have a high calcium and a low phosphate. They'll have history of renal stones, etc. But there's something to, I just thought it's important to cover this because I remembered it. That's all. Do you have any question on that?
No, sir.
Okay, all right. You understood that? No. So remember that these things are important in the exam. The endocrine doctors might have covered primary hyperparathyroidism, etc. But it's important to know primary hyperparathyroidism, secondary hyperparathyroidism, tertiary hyperparathyroidism, causes of hypocalcemia, hypercalcemia, etc.
Sir, in primary hyperparathyroidism, calcium will be more and phosphate will be less.
Correct, that's right. Because typically the renal function will be normal, no?
Normal, okay.
Because the PTH is able to work on the kidney, retain the calcium and get into the phosphate. And PTH also acts on the bone to release even more calcium. That's why the calcium levels are very high. In secondary, the calcium will be low, phosphate will be high because of renal failure. The most common cause of secondary hyperparathyroidism is CKD and followed by vitamin D deficiency. Yeah?
Okay, sir.
Just
Yeah.
a small doubt, sir.
Both will be.
In primary, you told us that the calcium is high.
Correct.
Phosphate is low.
Correct, Yama. Yeah.
Okay.
Yeah. Primary calcium is high, phosphate is low. Secondary calcium is low, phosphate is high. Tertiary both will be high.
Yes, sir.
The only other secondary you need to remember that is in case of vitamin D deficiency causing that is like lack of sun exposure, it's osteomalacia, both will be low.
Okay.
Yes.
So in secondary we have two types, either because of renal failure.
If it's due to CKD, because one of the kidney job is to retain the calcium and get rid of the phosphate. So if you CKD, what happens? The calcium will be low, phosphate will be high. Whereas in osteomalacia, it's not because of renal failure. It's purely because of vitamin D deficiency. And vitamin D is essential to absorb the calcium and phosphate from the gut. Yeah? Got it? No?
Yes.
You guys can hear me? Yeah, sorry, I thought, yeah. So it's bear that in mind. I know I went a little bit out, but it's because I remembered it when we had the thing about calcium and phosphate. Yeah, right. Okay. Now, a 58-year-old man presents to the emergency department with abdominal pain, fever, and vomiting. He is a known diabetic, hypertensive, and has end-stage renal failure, and he has treated with peritoneal dialysis at home 4 times a day. So just like hemodialysis, you guys are familiar with peritoneal dialysis, no?
No,
Yeah?
sir.
No.
Points.
Okay. Okay. See, hemodialysis is what we call is a blood purification. So you basically take a blood from the patient, take it to the machine, purify it, return it to the patient. Okay. So typically the patient will come to the hospital, has a dialysis, though it can be done at home. Typically they will come to the hospital, do it 2 to 3 times a week and go home and all of that. Peritoneal dialysis, what happens is, instead of using an artificial membrane, we are using the peritoneal membrane as a semipermeable membrane to remove the uremic waste products and the fluid. Yeah. So basically what we do is that we put a tube in the abdomen, which is placed between the 2 layers of peritoneum. So then what you do is that infuse bag of fluid, which is predominantly glucose based, dextrose. And what happens is, because of the equilibrium between the glucose level in the blood and the fluid, what happens is, as well as the concentration gradient, the uremic solutes will move to that PD fluid. And then after you leave the fluid for 4 hours, 3 to 4 hours, there are different variations of that, but that's what typically happens. You leave it for 3 to 4 hours and then drain it out of 4 hours. And what happened is that fluid would have sucked in some extra fluid, because glucose is also an osmotic agent, and it would have also removed some uremic components as well. But the problem with that is it's a very inefficient form compared to hemodialysis. So what you have to do is you have to do it about 3 to 4 times a day, every day. Whereas unlike hemodialysis, usually it's done 3 to 4 times a week. So this puts a lot of onus on the patient to do it. You have to do it very, very hygienically. There is obviously, because there is an artificial line being placed, catheter being placed, there is a risk of infection. Patients can develop peritonitis. Okay, that's probably the simplest form I describe it in. So this is more convenient for people who live far away from the dialysis center. Like, for example, let's say they are living 100, 200 kilometers of dialysis center, there's no nearby dialysis center, they can do it. But you do it very, very hygienically. But if you're not careful, you can easily introduce an infection. So sometimes what happens is patient relative will do it, some nurse or somebody will do it at home for them. That's what typically we see it in India and all. Abroad, a lot of people do it by themselves, which is typical because their patients are trained to do it at home. So if you look at efficiency-wise, there is very little difference between both hemodialysis and peritoneal dialysis with regards to the efficiency of dialysis, etc. It's actually a lot more gentler form, because hemodialysis you're doing it once every 2 to 3 days, no. So you tend to remove everything quickly over a short period of time. Whereas peritoneal dialysis is a lot more gentler. So it's supposedly a little bit better for patients with severe heart failure, patients who are frail, weak, finding it difficult to come to the hospital, etc. Okay. So that's a typical thing about what happens in peritoneal dialysis. So basically, this guy who's on peritoneal dialysis at home comes to the hospital with a fever, he's hypotensive, and he's got a distended, tense abdomen, and the fluid, peritoneal dialysis fluid is a bit cloudy, and you think that he may have a peritonitis. Okay, and the question is, what is the most likely cause of the peritonitis? That is what the question is.
Coagulase negative staph.
Coagulase negative staphylococcus.
Very good, very good, very good. Because this is the most likely organism because of the skin. I told you, the hygiene is very, very important. So they're not careful, the organism in the skin can escape into the peritoneal dialysis fluid. So that is the most common thing you will see. So coagulase negative staph is the most common cause in PD peritonitis. Whereas if you have a liver patient or somebody else who's got ascites for one reason or the other, they come with peritonitis, the most likely cause is going to be E. coli. Yeah. So this is, however, in PD patients, because they're doing it so many times in a day, etc. So they are more likely to be due to coagulation negative staphylococcus. 2 things you need to bear in mind. One is that if somebody is getting recurrent peritonitis, there's a scenario, particularly in part 2, people are getting recurrent peritonitis. One important thing you need to bear in mind is they may be more vulnerable to fungal peritonitis, because you give repeated courses of antibiotics, things are not improving. So then they may land up with a fungal peritonitis. It's just something to bear in mind. Rarely you can have particularly if they give a scenario from Asian patient, etc. Rarely you may get a TB peritonitis as well. Those things are rare, but does happen. So just some two to three things to bear in mind. I mean, rarely there is a serious infection, they may have to remove the catheter and put them on hemodialysis for the time being. And then if, as and when things settle down, you may have to go back to peritoneal dialysis again. So, but it's more convenient for people who live particularly quite far from their dialysis center, etc. Okay? Right. Any question on that?
No, sir.
Yeah, just to bear in mind, similar question, for example, what happens in hemodialysis, again, you can get those infections, but typically only in patients with the line. With the fistula, you are all familiar with the fistula, no? Arteriovenous fistula. We connect an artery and a vein together. Yeah?
Yes, sir.
Yeah. So there, the risk of infection is very, very low because you are not putting anything in there. You're just connecting your own artery and the vein. But if you put a line, then again you have the same risk of infection, like a temporal line or a perm cath. So if a dialysis patient comes in, who's got a catheter in place, comes in with fever, chills, again the top differential will be line infection in those patients. Okay? Just something to bear in mind if they have a dialysis catheter in place. Yeah?
Sir, enterococcus also one of the causes of this.
What did you say? Sorry?
Enterococcus.
Enterococcus
can be the one of the cause of patients.
No, it can enterococcus, did you say?
Yeah.
Yeah, that can also happen. So all these infections can happen. The question is, what is the most likely cause?
That is coagulous negative.
It's possible. No, all enterococcus faecalis, particularly if there's a bowel issue or something can develop, that bowel perf or something like that can happen. But the common cause is coagulous negative, purely because of the skin exposure. They are doing the dialysis free repeatedly. They're not being careful with the hands, washing the hands, etc. Then they can develop that. Okay. Okay. Yeah. Right. Okay. So that's the most common cause. It's an E. coli and spontaneous bacterial peritonitis, etc.
Okay, sir.
Right. A 60-year-old woman attends the dermatology outpatient clinic due to lesion in the left ear, which has grown quickly over the past 4 weeks. On examination, there's an ulcerated lesion with irregular border in the pin of the left ear. She had a history of bleeding. Occasionally, it's been painful, and she has a history of type 2 diabetes mellitus and had a kidney transplant about 10 years ago. Okay, so it's a lady who's immunocompromised or immunosuppressed, who also diabetic, so two major risk factors, now comes in with the lesion in the ear, which is bleeding at times and also painful. So it's in the ear or pin or whatever. That's what she's got. So what is the most likely cause of this lesion?
Squamous cell carcinoma.
Is there anything else which is possible? What if, let's say, what would you thought if she didn't have a transplant? What do you think of it?
Alperson.
Immunity
compromise.
Sorry?
Basal cell.
Yeah, that's right. No, that's right. Yeah. I mean, so pyoderma cancer doesn't happen there. Kaposis, unless you think of HIV, malignant melanoma is very, very unlikely. So if it's a transplant patient, these patients are immunosuppressed patients, they are more likely to develop squamous cell carcinoma. However, in the general population, if it is a non-transplant patient, you have to think of basal cell carcinoma. Okay, so renal transplant patients, particularly patients who are immunosuppressed, are higher risk of skin cancer. So here, given the situation, patients immunocompromised status, it's more likely to be squamous cell carcinoma. So as I said, it's commonly you see that in sun-exposed areas. We generally, particularly the people who got a fair skin, we advise them to use sun cream, etc. when they're going out in the sun. But because these patients are taking immunosuppressive drugs, that increases the risk of malignancy, etc. What are the other things? I mean, again, same time I will try and cover so that because it's impossible to have a question on everything. Apart from the malignancy, what else you have to be worried about in kidney transplant patients? I think we discussed some of the side effects of cyclosporine tacrolimus the other day from my memory. Yeah, 10 days back when I had the class. Yeah, you guys may remember that?
Yes, sir.
Yes, sir.
Yeah. Okay, yeah, okay. So what are the other side effects one need to be bear in mind?
Increased risk of infections post-transplant.
Correct, okay, yeah.
Rejection.
So the first,
Risk of rejection.
yeah, so the first,
rejection.
yeah, so yes, that's right.
Cyclomicrovirus, risk of cyclomicrovirus.
Yeah, so the already somebody mentioned infection. So particularly if it happens in the first few months, the top differential is going to be some sort of infection, and the most common ones being PCP. Though we usually give prophylaxis, so we see that very rarely. CME also we give prophylaxis, but some people can develop CME. And you think of CME, you remember the other day I said CME if you suspect if they have a hepatitis, thrombocytopenia, leukopenia, etc. Yeah, you remember that?
Yes.
Yeah. So PCP,
Yes,
generally,
sir.
when will you think of PCP?
Hypoxia, desaturation on exertion.
Exactly, that's right. Particularly hypoxia, desaturation, exertion. Yeah. So if they're not mentioning hypoxia, they're not mentioning desaturation, it's less likely. You can never say never, obviously. But CMV, you think of it, they mention hepatitis, they mention thrombocytopenia or bowel involvement like colitis or
Colitis.
thrombocytopenia. Yeah. All those things you have to think of CME. So that's other things in the acute phases. Obviously, the other common thing will be acute rejection. But generally, they tend to present with a graft tenderness, increased creatinine. Though they can develop fever, it's unusual for people to present with fever just with acute rejection. Fever is more common when there is evidence of infection, etc. Okay, so acute rejection is likely infections. These are the common infections. I mean, they can develop any other infections. So, any other infections can happen, but over the longer term, you tend to think of infections like TB, increased risk of cardiovascular disease, and risk of malignancy. So they had a transplant for a longer period of time. Then they have a higher risk of malignancies, both the solid organ malignancies, etc. If they have infections for the other malignancy, one need to be aware of. I mean, this may or may not get asked in MRCP level. There's something called post-transplant lymphoproliferative disorder. You heard about that? People present with you guys familiar with that or heard about it?
Yes.
Yeah. So post-transplant lymphoproliferative disorder. Why? Exact. Very good. It's linked with Epstein-Barr virus. Yeah, that's right. Yeah. So that is also something. But again, this is very, very rare, particularly people who are heavily immunosuppressed, but more than one organ transplant, who had what we call is incompatible transplantation. That's like a blood group incompatible transplantation. Though they would be heavily immunosuppressed.
Sir, but it takes place only after long period of time, right?
Correct. Yeah, few years. I mean, it doesn't have to be very long. Generally, it happens more than 5 years after transplantation. But we see more often around 10 years or so, something like that. But it can happen earlier as well. But it tends to be rare. There's something to bear in mind. If somebody is giving diagnosis of patient presenting with multiple lymph nodes post-transplant, so that's something you have to think of. But these patients are also at risk of increased risk of other malignancies as well. Whether it is a colorectal cancer, etc. They have a higher risk of malignancy because you are immunosuppressing them. Okay. Right. Another question. You have a 68-year-old lady who's come to the hospital, and the nurses have noticed that she is not passing much urine. She was initially admitted with pneumonia and now has developed diarrhea, presumably related to antibiotics. And you note that the serum creatinine is nearly doubled, increased from 98 to 172 micromoles per liter. And so you were worried. So you got a patient who's come to the hospital. She's developed an acute kidney injury, and you were worried whether it's going to be pre-renal or renal. Very unlikely to something to be post-renal. There's not much history. It could be post-renal as well. So here the question is, what are the following tests you can do which will help you to decide? Sorry, just 1 second. I just needed a paper. Yeah. Which are the following helps you to decide whether this is a pre-renal AKI or an acute tubular necrosis? That is what the question is. So urea level, hemoglobin concentration, plasma osmolality, urinary creatinine, and urinary sodium.
Urinary sodium.
Urinary sodium.
Very good. So what will you anyone? What will be the so let's say that this lady has got a pre-renal renal failure. Okay. So that's basically it's related to, why do they develop pre-renal? Because it's related to
Diarrhea.
yeah, diarrhea, hypolemia. Yeah, that's what I meant. Yeah,
Hypolemia.
diarrhea. Obviously, hypolemia, pneumonia. She may not be eating properly. Just to make things a little bit more worse, she's also developed diarrhea. So she would have got even more dehydrated than already, and now she did an acute kidney injury. Okay, so
Yes.
so what you let's say you suspect that this lady's got a pre-renal AKI. So what do you expect the urinary sodium to be?
Renal
So-
sodium
It will be less.
Sodium would
Less than 20, sir.
Less than
Less than
20.
20.
Yeah, very good. Yeah, urinary sodium will be less. What is the other fancy test you can do?
Fractional excretion of sodium.
Fractional
Excellent.
excretion of
Okay. That will be low as well. Yeah,
Yes.
that takes
Low.
into account of the urinary concentration as well. So urinary sodium or urinary. So you got that. So when you have a AKI, which is due to a hypolimic insult, which could be absolute or relative, like in this setting, it could be vomiting, diarrhea, hypovolemia, etc. There is decreased renal perfusion. So what will the kidney normally do? You will activate your renin-angiotensin system, and your kidney will try to conserve the sodium. Yeah.
consumption.
Yeah. So your urinary sodium should be low.
Yes.
Less than
However, let's say this has gone on for about 5 days. This lady has become increasingly oliguric. Let's say she's set in 18 as set in. That's acute tubular necrosis. Now, what would you expect the urinary sodium to be?
It will be more than
Great,
40.
Okay. Why is it important to know what difference it's going to make to your management?
Repeat.
the filtration function of the kidneys.
Sodium is lost.
Yeah. So now, why do we need to know whether it is simply a pre-renal AKI or she's got an acute tubular necrosis?
Because is important for treatment.
So what treatment? How does it make a difference? I'm asking.
By giving fluids, probably pre-renal can
Yeah, exactly. That's right. Yeah. So
Hydration.
that is why it's important. Yeah. So whereas if 18 is completely set in, they may go into a volume unresponsive phase. Yeah. Whereas if they're still in the pre-renal phase, they may respond to volume. So that is why it's important to know. Yeah. Got it? Yeah.
Okay.
Yes.
Yeah. So if somebody's, because they may still be a little bit hypertensive, but somebody's got a 18 as set in, give them a lot of fluids, what will happen? They will develop
And
pulmonary edema. No, pulmonary edema they will develop. Yeah, fluid overload. Yeah.
Fluid
Whereas
overload.
they're still in the pre-renal phase, the kidney is still trying to conserve the sodium, give the fluids. They may recover from acute kidney injury. Yeah.
Yes,
Okay.
sir.
yes, sir.
Yeah. Got it? Yeah.
Yes.
So that's what the urinary sodium will help. None of the other tests are going to be useful. The difference between urea, creatinine, etc., they're all very old-fashioned, really. And urinary sodium also can be misleading at times. When do you have to bear that in mind? When can urinary sodium be misleading?
When you have associated
Side. Hyponatremia, sir.
No, that doesn't matter. No, it can be hyponatremic and hypolimic. What will happen to older people? What drug will they be taking often?
acids
Exactly. Yeah. So then what will urinary sodium be?
lower.
High. No, it will be high. You take a
Yeah.
thiazide, what will happen to
Yeah,
the
yeah.
sodium?
Yeah. High.
Yeah.
High.
So that's why it's important to bear that. That's why the history and drug history is very, very important. If you're taking an thiazide or a loop diuretic, your urinary sodium is going to be high. So you have to take that into account. I mean,
High.
that's just outside in terms of thinking, I'm just saying, because that maybe sometimes can mislead you. If let's say old ladies are taking thiazide diuretics are commonly prescribed for hypertension. No, elderly people with hypertension, systolic hypertension, particularly thiazides are commonly used. So if those patients are taking antihypertensives, particularly taking diuretics, they may have heart failure and taking a loop diuretic like furosemide, tarsemide, etc. So then your urinary sodium can be misleading. So it's just important to bear that in mind. But that primarily this is the purpose. You check the urinary sodium. If it's low, it may indicate a volume responsive phase. You can correct the volume and things may improve. Or if the urinary sodium is high, it could suggest that there's an 18 as set in. They may not respond to volume so much, and you may have to go for dialysis or something like that if things are not improving. Okay, just that sort of thing would help. Okay, just one additional question on the same thing. What else? What one test will I say you will do to decide whether there is something more than what is going on there in this patient? What one additional test to do you can do apart from the
Fractional sodium.
sorry?
Fractional sodium.
Sorry, Ma, what did you say? What sodium? We already mentioned that, no.
Osmolality, sir.
Osmolality, sir.
Osmolality is not necessarily going to help very much. The test I would be thinking of would be urine routine.
Oh.
Because if it's pre-renal, what do you expect the urine to be? Yeah, exactly. If it's a pre-renal AKI, what do you expect the urine to be?
Oliguria.
Sorry?
Cast will be seen in ATN.
Bland.
It will be bland. There will be nothing will be there. Because there's nothing wrong with the kidney, ideally, yeah? So if you have a pre-renal renal AKI, your urine should be bland. There's very unlikely they should have a proteinuria, hematuria, etc. Because unless they have some other pre-existing kidney disease which is giving you that, they're not going to have anything in the urine. That is why we typically call it a bland urine. If it's ATN acetyl, what you might see in the urine? You might see
granular cast.
Exactly, that's right. Yeah. So granular cast. Whereas at the same time, this patient got a, let's say, AK related to the infection, some sort of a granular interstitial, some sort of a GN, then glomerulonephritis, then you may find proteinuria and hematuria. Yeah? That's also important. That's why urine routine is very, very valuable in this sort of situation. You give an idea that there is something more than what you think is going on with this patient. Okay. So urinary sodium will help you differentiate whether it is a pre-renal or ATN acetin. Urine routine will help you decide whether there could be something active going on in the kidney or not. And ultrasound will help you to decide whether there is a post-renal obstruction or not. So that is why you're thinking, no, you got a patient with an acute kidney injury. You're thinking whether could this be pre-renal, where it could be, a pre-renal hypolimic response or an ATN, or it could be a intrinsic kidney disease where it could be glomerular or tubular interstitial, or a post-renal where there is obstruction. So the urine routine is going to help you whether it could be a intrinsic kidney disease where the patient has got a active urine, proteinuria, hematuria, obviously presence of hypertension, etc. Well, all of that will help you to decide that. Okay. Right, next question. A 70-year-old male has been scheduled to undergo coronary angiogram for evaluation of cardiac disease. He's got a medical history of diabetes, hypertension, and obesity. He's currently taking ecosprin, metformin, and amlodipine. What steps should be taken for 48 hours post-procedure? So you got a guy who's going to go for an angiogram. He's taking these medications. Obviously, you're worried about contrast nephropathy. Yeah, that is what you are concerned about. So the question is, what can you do to minimize? You can't eliminate the risk like most things. So you can do something to try and reduce the risk. So what can you do?
Hydrate.
But for me,
Metformin.
Hydrate.
Yeah,
Stop.
yeah, that's right. I mean, the two things you already mentioned that. One is that this is the options actually. You can tell me, give large volume of IV resuscitation, give N-acetylcysteine, hold aspirin, hold metformin, and then monitor renal function. And if no deterioration, no further action is required. So you already mentioned that. So the most important thing is stop metformin. You give fluids, but not necessarily large volumes of fluid because you need to be careful in these sort of patients. N-acetylcysteine, some people do use it, but the evidence is a little bit patchy. So the most important thing is to stop metformin. Now, what are the other risk factors for contrast nephropathy?
Sir, can I ask a question, sir?
Yeah, definitely.
Sir, will stopping holding metformin after the procedure, is it going to improve or it has to be stopped?
No. Ideally, you should stop. See, giving till usually generally stop it from the day of the procedure. Usually, yeah.
Not before the procedure. 48 hours before the procedure, sir.
No, you don't need to. No, generally, we don't need to stop it the day before. I think the question has been, what you normally do is you tell them, because they're going to have contrast nephropathy only after the procedure. No. So generally what we do is you tell them we don't give it on the day of the procedure and they don't give it for 2 days after the procedure.
But the contrast nephropathy is more prominent mostly on the 3rd day, sir. The 3rd to 5th day.
Yeah. I mean, the point is, what we normally do is that, see, that's because you're seeing it later. See, what happens is, see, the creatinine, that is one of the big problems with the creatinine. So let's say even if somebody's got a normal kidney function today, let's say they got a creatinine of 1, I remove both their kidneys. When do you think the creatinine will be 5 or 6? It'll take 40 to 70 hours later only.
Yes, sir.
Because it takes time for it to show up in the creatinine. You see that frequently in patients coming with acute kidney injury, they will come, they won't pass any urine. You will see the creatinine is hardly changed, isn't it? Have you not seen that in clinical practice?
Yes, yes.
They will come. Yeah. So that's why it takes time for the creatinine. It doesn't mean that they're developing AK only 3 days later. It just takes time for you to see the increased creatinine. That is why we are looking at various markers now.
Okay, yes, yes.
There are urinary, NGAL, also sort of things are all there now to check whether they are developing AKI already, because creatinine is not very good in detecting AKI.
Okay, sir. Okay.
Sometimes you actually, the pre-existing, particularly when you don't know the previous creatinine, you may find 1.2, but you might think it's normal, but actually the pre-procedure creatinine may be 0.9 or something like that.
Okay,
but because in the reference range, we might have ignored it.
okay.
Got it? Yeah.
Because
So
what I thought for the answer was monitor renal function, based on that you can decide on. Because not pre-procedure, so post-procedure.
Okay. Yeah, no, I mean, you also advise some, you will definitely check the kidney function after 2 to 3 days, because as you said, that is when you will see the result. But in terms of preempting it, maybe the question is probably not worded correctly. Preempting it to stop, to reduce the risk, what you do is you stop the metformin for 48 hours. But my other question, you guys may have overlooked it. What are the other risk factors for contrast nephropathy apart from metformin?
Diabetes mellitus?
Yes, that's one of the major risk factors for contrast nephropathy is presence of type 2, presence of diabetes. Yeah.
Most important is presence of LV dysfunction, sir.
Yeah, correct. Again, why do they have, why is that a risk factor?
Because it has gone for the output is low, sir, cardiac output.
Exactly, that's right. You have a reduced effective arterial volume. Yeah. So the same applies if somebody is hypotensive, hypolimic, or severe heart failure, they got reduced renal perfusion, they will be at risk of contrast nephropathy. Sometimes they can develop pulmonary edema actually post-procedure, because these contrast agents can cause vasoconstriction. Yeah. So that is why they can develop pulmonary edema. Sometimes we have to dialyze these patients after the procedure, particularly those with severe renal impairment, etc. Yeah. Okay. One, hypolimic status or reduced effective arterial volume. Diabetes, you guys already mentioned. Any other risk factors you're familiar with?
It's a history of MI.
MI itself is not a risk factor. No, there is one other condition you need to bear that in mind. That's why
Hypertension.
No, hypertension is not a risk factor. No.
Associated drug intake, which can NSAIDs and all.
Yeah, NSAIDs and all that. Probably you can take that, but yeah, there's one other major risk factor, one particular group vulnerable for it. That is patients with multiple myeloma. You not heard about that? Not heard that? Because there is increased proteins. So what happens is that they are more at risk of vasoconstriction. So multiple myeloma I meant. Yeah? You guys not heard that before?
No, sir. Probably.
Okay. Multiple myeloma is one of the risk factors. Yeah. So it's so obviously presence of renal impairment. We already mentioned that. Old use of nephrotoxic drugs. And then multiple myeloma.
Grocery crockery household items steel shop.
Some other voices I'm hearing. Okay. So now, normally what you do is that you give them some fluids, and one of the most important aspect to reduce the risk of contrast nephropathy is volume correction of volume status. So you can give them a prehydration when you're going for a particularly intravenous contrast media, because the risk of contrast nephropathy much more when you go for coronary angiogram than, let's say, CT angiogram, etc. comparatively, because the volume of contrast used is much more higher. So you give them fluids.
Also, we
sorry, pa?
The amount of the type of dye used also will determine.
Yeah, correct. Yeah, that's very good. Actually, you guys are familiar with that?
I'm a cardiologist, so I just.
Oh, okay, fine. Yeah, so what we do is we use isoosmolar contrast media. You're familiar with that, isn't it? I mean, yeah. So they are. There's some other voice in it. Yeah. See, the isoosmolar contrast media, that's why you were referring to, no? The one brand that we have here is Recipe. Yeah. So that is got a relatively lower risk compared to the other contrast media, because they generally tend to have a much higher osmolality. Sorry, just 1 second. I'm hearing a lot of other
സ്റ്റെയിൻലെസ്
voices.
സ്റ്റീലിന്റെ ഇതുണ്ടാകാം മറ്റേ നമ്മളെ ജാറ് പോലത്തത്. മിക്സി അല്ല, സ്റ്റെയിൻലെസ് സ്റ്റീലിന്റെ ഒരു
Sir, I'm
നമ്മുടെ
hearing
ജാറ് പോലെ
some other
എണ്ണ ഇട്ട്
voice.
വെക്കാനുള്ള ഒരു ബോട്ടിലല്ലേ, അതുപോലത്തെ സ്റ്റെയിൽ ഇല്ലല്ലേ? ഓക്കെ.
Option. Sorry. Can you guys hear me now?
Yes, sir. Yes, sir.
Sorry, I was hearing some other voice. That's why I had to stop it. Just 1 second. Okay, so you heard that when we are discussing it, what I mean is the isoosmolar contrast media. So basically, they have as the name implies, obviously as a cardiologist, you should be familiar with them. Their name implies their osmolality is similar to plasma osmolality. Yeah. So then supposedly they have a lower risk contrast nephropathy compared to other osmotic media, which tend to have a much higher osmolality. Because the major mechanisms by which these drugs cause contrast nephropathy is by inducing vasoconstriction. Okay, so that is why. So some people do give N-acetylcysteine, but there's very little evidence for that. The important thing is to correct the volume status, stop the offending drugs, and monitor the kidney function. Right, next question. A 22-year-old woman is referred to the nephrology department after experiencing several episodes of visible hematuria. She has no history of abdominal pain or loin pain. This typically occurs within 1 or 2 days of developing tonsillitis. Her blood pressure is a little bit high, urine routine and blood tests are all normal. Okay. So what is the likely diagnosis? It's very easy actually.
IgA nephropathy.
IgA.
What will be the differential you will think of?
Post-streptococcal glomerular.
Very good, very good, very good. How do you differentiate that?
Depends on the duration.
One of them, please. Yeah. One of them, please. Yeah.
More than 3 weeks, we mostly suspect.
Generally happens after not necessarily 3 weeks, but generally there is a little bit of a gap before they develop the infection and then coming up with acute kidney injury. Okay. Second,
Duration.
Duration, we just mentioned that, no? Yeah, somebody just said that happens after the, and then?
Visible hematuria.
You already mentioned visible hematuria. It's not actually typically post-streptococcal, you don't necessarily get visible hematuria. It's more typical, you see that in IgA nephropathy. Yeah, hypertension can present in both the conditions, but typically in post-streptococcal, generally the blood pressure tends to be quite high. Yeah. Rashes people don't necessarily develop. Yeah. That's you're probably thinking of Henoch-Schönlein purpura, I think. Typically post-streptococcal, you don't develop a rash. But what will happen to the urine and the renal function?
Renal function will be severely.
They will have a post-streptoglomerular. They will have generally have a progressive rapidly progressive glomerulonephritis. So they tend to be hypertensive. They tend to have a high creatinine. They tend to have an active urine with proteinuria, hematuria, etc. So that will give you the hint that this is most likely to be post-streptococcal. I mean, other investigations may also give you a clue. What investigations can you specifically do if you think of post-streptococcal glomerulonephritis?
ASO titer.
Yeah, good. That one. Second,
renal biopsy.
You can do renal biopsy before that. Any other blood investigations you can do apart from creatinine, electrolytes, etc.
Total counts.
The total count may not give you complements. Exactly. Good. Very good. Yeah. So complements will be typically low in post-streptococcal glomerulonephritis. So you have a scenario like somebody who has got a sore throat, coming with renal failure, hypertensive, often they will have features of fluid overload, and they get a low complement, or the test you do will be complements that will give you the hint that this could be a post-streptococcal glomerulonephritis. Yeah. Whereas in IgA nephropathy, typically they can present with crescentic glomerulonephritis as well, but this sort of patient typically do not have other features of glomerulonephritis. So, which of the following is a marker of poor prognosis? That was the question. Frank hematuria, absence of proteinuria, development of disease before 20 years, female gender, and hypertension.
Hypertension.
Yeah. So you remember that with regards to any kidney disease, the most important marker of prognosis are prognosis, hypertension, and
absence of proteinuria.
No, I meant poor prognostic markers. Presence of proteinuria. Yeah. So the degree of proteinuria indicates a poor prognosis. Yeah, that's right. Yeah.
In male age also, sir.
Male age has
sex.
got a risk factor in some conditions, but typically speaking, with regards to any renal condition, the most adverse prognostic markers are hypertension and degree of proteinuria. If somebody's got a lot of proteinuria, the prognosis is much worse than somebody's got a non-nephrotic proteinuria. Yeah, so that's why it's important when you have a patient with renal disease, you monitor the blood pressure, control the blood pressure, monitor the proteinuria, and treat the or reduce the proteinuria with ACRB, etc. So any kidney disease, remember that the two things is presence of hypertension and degree of proteinuria. Okay, so male increased proteinuria, hypertension, smoking, yes, genotype DD, etc. But so the most important things are proteinuria and presence of hypertension. Okay, right. This is a very relatively simple question. We'll just do a couple of more questions. You got a 15-year-old male who's presented with minimal change disease. Now, the question is, which of the following is the most likely outcome in a patient with minimal change disease? Number one, CKD requiring dialysis within 30 years, full recovery and no further episodes, full recovery with relapses. Number four, CKD not requiring renal replacement therapy. And number five, CKD requiring dialysis within 10 years. Relatively easy question, actually.
Full
recovery.
With the later relapses.
Yeah, that's right. So you remember that with regards to any glomerulonephritis, the best glomerulonephritis for anybody is to have is actually minimal change disease, because it generally does not lead to chronic kidney disease, does not lead to severe renal failure requiring dialysis. Generally, for most patients, that I said there will always be exceptions, but generally it's a remitting and relapsing disease. And particularly when they're younger, they tend to have a lot more frequent relapses. As they get older, the relapses tend to be less common, but typically presents with remitting and relapses, repeated relapses of nephrotic syndrome. So you typically treat them with, we already discussed the other day.
Steroids.
Yeah, that's right. Steroids is the first line, and generally you would see a response within 1 or 2 weeks generally in most patients. So adults can take a little bit longer. So typically they don't develop end-stage renal failure requiring dialysis or worsening kidney function. Sometimes in the acute phase, they may have a raised creatinine, usually due to acute tubular necrosis related to the nephrotic syndrome itself. But typically, they don't develop it. Yeah, but typically they don't develop it. There's something to bear in mind. So full recovery, they may relapse. Prognosis generally is good, though they can have relapses, and almost always present in nephrotic syndrome. And it's the most common cause of nephrotic syndrome in children, and probably the second or the third most common cause of nephrotic syndrome in adults. The adults, the most common cause is membranous nephropathy. Yeah, right. Next question. So yeah, we'll do 1 or 2 additional questions because I start a little bit late. Yeah. Now, the next question is, 28-year-old woman comes to the rheumatology clinic for review. She's got history of SLE and stopped the medications prior to getting pregnant. And now she's approaching 16 weeks of gestation. She's got joint pains, and the serum creatinine has increased from 90 to 140, so nearly gone up by about 50%. She's got active urine with proteinuria despite high-dose steroids. Which of the following is the most appropriate next step? So this lady who's got SLE, she's pregnant, she's 16 weeks pregnancy, and she's got increase in creatinine with proteinuria and hematuria. So what can you do for this lady?
So thank you.
Everybody agrees? Okay.
Yes.
So what about cyclosporine? Can it be used?
Contraindication.
Contraindicated.
No, it's not contraindicated in pregnancy. It can be used actually. We do use it for transplant patients, but it's not necessarily the drug of choice for SLE. Yeah. Okay. You can actually, transplant patients can go, renal transplant patients, no? So when they go through pregnancy, they can take cyclosporine or tacrolimus. Usually it's not a problem. I mean, there is some increases of malformations, etc. But generally, it can be used because often for renal transplantation, you can't stop these drugs. But and usually the safest drugs are cyclosporine or tacrolimus, azathioprine plus or minus the steroids. But here the indication is for SLE. SLE, we don't generally use cyclosporine or tacrolimus. We may use it for the type 5 SLE nephritis. Do you remember what that is? We discussed the other day. What is class 5 SLE nephritis? You've forgotten. We had a
membranous.
Huh? Exactly. That's right. Yeah, membranous we can use cyclosporine. But here it's not. It's unlikely to be beneficial. particularly with regards to the joint symptoms, protein, increased creatinine, etc. So because cyclosporine itself can increase your creatinine, it's going to be even more of a problem. So it can be used, but in this situation, because she's got the SLE and evidence of joint pain, the worsening kidney function, the safest or the best drug of choice is azathioprine. Okay, cyclophosphamide methotrexate, MMF, complete no-no in pregnancy. We cannot use them at all. Cyclosporine in a kidney transplant patients, we can continue them during pregnancy. Okay. Yeah. Got that?
Okay, sir.
Okay.
Yeah.
Yes, sir.
So all these other drugs, cyclophosphamide can be used, but in this condition, you cannot use it purely because of the reasons I mentioned, but it can be used during pregnancy. We do use it for renal transplant patients. Right. Okay, I'll just finish a couple of more questions because I started 5 minutes late. Which of the following, all these conditions cause nephrogenic in diabetes insipidus except? It's a relatively simple question. We discussed it the other day, actually, diabetes insipidus, you may remember. So which of the following does not cause diabetes insipidus? That is the question. Yeah, very easy, actually. Yeah, that's right. Yeah, that's right. Hypercalcemia is the cause of diabetes. It will cause polyuria. It will cause polyuria, thirst, etc. So hypocalcemia is not a cause of this. Very easy question. I'll just do this last question because it's important. I've not had a question on this before. Okay, so it's you have a 24-year-old guy brought to the emergency department after being found unconscious by the flatmate with a tourniquet attached and needles by the bedside. He has been using some unknown drug. He's been like this for a unknown amount of time. He's IV drug user, no significant past medical history, does not take any regular medications. His pupils are 2 millimeters bilaterally, chest is clear, and he just is a little bit painful when he presses thighs or legs bilaterally, not responding to questions. Oops, sorry. So these are the answers. These are the electrolytes. You've got a sodium of 148, potassium is 6.9, bicarbonate is 18, serum creatinine is elevated at 350 micromoles per liter, calcium is 1.9, which is a bit low, and serum phosphate is 1.7, which is a little bit high. So yeah, I'll have 2 questions on that. Well, one question I'll show you in a minute. So what is the most likely diagnosis?
Rhabdomyolysis.
Excellent. Very good. So as evidenced by hyperkalemia, hypocalcemia, and hyperphosphatemia. Yeah?
Yes, sir.
So you have a lot of muscle death. You have a increased damage to the cells. So you get high potassium, and because the cells also release a lot of phosphate, so that's why the phosphate is high, and this phosphate will directly bind to the calcium, etc. So usually you drop the calcium levels. So if you have a situation where you got hypocalcemia, hyperphosphatemia, hyperkalemia with metabolic acidosis, your top differential is rhabdomyolysis. So what investigation will you do?
Creatinine kinase.
Tyrosine kinase.
Yeah, that's right. So serum creatinine kinase or?
High.
So urine myoglobin.
Exactly.
Myoglobin.
So either of the tests will
Myoglobin.
give you the answer. Yeah. So you can do a serum creatinine kinase, or if the other option is if they're
And
giving a
urine
urine myoglobin can also be checked. So sorry, just 1 second. Sorry, yeah. You think of that. The sometimes the other question sometimes they ask in this situation is there will be an old lady found on the bed for a floor for a long period of time, and they may give a hint that the urine shows blood or something like that. Okay, the myoglobin sometimes is tested as blood by some of the urine dipsticks. You got that? You remember that? Having questions like that. So sometimes they will ask a question like that. Urine shows blood, but there's no protein, and you check the urine for myoglobin, that will come back as positive. Yeah. So because that also have to bear that. My old lady, found in a nursing home, unresponsive for a few hours or something like that. You always have to think of rhabdomyolysis. So what are the drugs which are implicated in that? He's IV drug user on the floor for a long time. What are the other things you have to think of? Huh? Sorry?
Hydration.
No,
Hyperlipid.
that is a treatment. No. I'm talking what are the other drugs which are implicated in this condition I'm asking?
Nystatin.
Heroin.
Huh? Sorry?
Heroin.
Not steroids. No, not steroids.
Statin.
Heroin.
Yes, statins, fibrates, idostatin, particularly very high strength statins like rosuvastatin, etc. So use of statins, sometimes they'll give a scenario that somebody had a MI, has been started on a statin, comes with muscle pain, and due to the test, this is what you find. So you have to think of that. That's one of the other reasons for rhabdomyolysis is statins, particularly high doses of more potent statins like rosuvastatin. It can happen with any statin, but it's more common with, let's say, rosuvastatin than atorvastatin, etc. Yeah, so that's also something to bear in mind. Okay, I think I'll stop with that. Any questions?
Sir, how statin does work in this nephromesis case?
No, it's purely because of the muscle damage, really. That's all. Yeah. Statins cause myositis. No, that is why it happens. Yeah. So the more potent the statin is, the more likely that they're going to develop myositis. So sometimes they may give history that patients have got a muscle pain or a back pain, etc. They may give a back spasm, etc. So it's purely because of in myositis inflammation. You have increased risk of creatine kinase that will go and deposit in the the kidneys, and thereby you develop rhabdomyolysis. Yeah.
In other cases of muscle pain, can we use the statin also?
Other cases of what?
Other than the fibromyalgia, muscle pain, any athletes running.
Sorry, can you use
statin?
After rhabdomyolysis? You are asking.
After rhabdomyolysis, but in case of any generalized muscle pain or
you can think of it, sir. You will not think of pain. Yeah, I mean that also can happen. Rarely you can develop that. You can think of it. I mean, if you check the CK, you will know. No, but obviously, as you said, sometimes you can get it with post some infections, etc. But if they are taking statins, that could be some other trigger which could have triggered it or something like that, like dehydration, hypovolemia could have aggravated it, or combination of other drugs like fibrates can also aggravate that. So if they really absolutely need statin, you can go for a lower strength statin or a lower strength, like a less potent statin, like a atorvastatin on a lower dose compared to something like a rosuvastatin, which is more potent. So its risk is much more higher. Yeah. Okay.
Thank you.
All right. Okay. Thank you. Okay. Good night, guys. Okay. Thank you. Any other questions? Sorry, before I stop, I forgot to ask. Okay. All right. Okay, guys. Good night. Okay.
Thanks.
Bye.
Good night.
All right. Thank you.